Starting, all attendees are in listen-only mode.
Good morning. Thanks for joining us today for our webinar. My name is Carmen Boone. I'm an education coordinator from Oregon Pacific Area Health Education Center, and we're a hosted agency of Samaritan Lebanon Community Hospital. Our agency mission is to promote access to quality healthcare through community and educational partnership. Today, I'll be your host and moderator. Let's go over some housekeeping items as usual. On your GoToWebinar control panel, you will notice that all microphones are muted. They'll remain muted during this session. If you experience audio difficulties, make sure your computer speaker volume is turned up, or use the phone option to listen in. You may download today's slides from the handouts menu. Send us an email request if you have any problem. I'll be sending you all an email after this session within an hour or so to let you know more about the handouts and the CME claiming process. Use the questions menu to type any questions at any time. We'll answer them at the end. And if we run out of time, we'll answer it anyways via email. This webinar is being recorded and will be available on our YouTube channel. So you can see the link there. I'll include it on our email too. If you have any questions, send me an email. Now to obtain CME, CE credit, or certificate of attendance, log into EADS, www.eeds.com. and write down this code. This code is for today's activity and it expires within a week. So keep mind on that. We will email you all these instructions today within 1 hour. So no worries if you didn't get it. This presentation is jointly provided by Samaritan Health Services, Oregon AHEC, Oregon Health and Science University, and Oregon Pacific AHEC. The presenters and the planners of this activity report that we have no conflicts of interest or relevant financial relationships with any commercial entities that might affect the contents of this presentation. And this webinar is presented by Tina Runyan and Joan Fleishman. And Tina is a professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School. We've been working with her in this mental health series for our 2 previous sessions, as we know that she is a national recognized leader in collaborative care, which focuses on bringing accessible mental health care into medical settings, especially for underserved communities. Joan, Dr. Fleishman, completed her graduate training at Pacific University School of Professional Graduate Psychology and completed a fellowship in primary care psychology at University of Massachusetts Medical School. She is with Tina, they are co-founders of Tent Health, and Joan specializes in providing low-barrier mental health care to healthcare providers in Oregon and Washington. And right now I will leave you with our presenters, and Tina and Joan, the floor is yours. Joan, you self-muted. Okay. So I apologize. We're having troubles with our audio settings. Let us try to figure this out. Just a moment. I'm gonna stop my webcam right now. Okay. Okay, Tina and Joan, you both on your control panel, if you see the list of attendees, you will see your names, and then under staff, you will see your names, and then at the bottom, there is an orange and blue microphone icon. Can you click on the green one that says unmute all, and you'll get a mute all attendees, and then click yes. Okay. I'm sorry, audience, everybody that is joining us. I'm so sorry for these difficulties. Everything was working great. So let's try this again.
Now can you hear me?
Yes, perfect.
Okay. Something about needing to come back in and come back out.
Okay.
So let me say what I said before. Let me see if I can get my webcam on. So much for a nice long tech check. Good. Yeah, give me a second, Carmen. I gotta reorganize everything since I quit.
Yes, no problem. And thank you for all participants for being with us and hanging out with us. You know, electronics, computers are a big part of our time or lives today. And thanks for bearing with us.
Okay. So you can all hear me and you can see the screen, yes?
Yes.
Wonderful, wonderful. So I just said while I was muted was just thank you so much, Carmen, for the introduction, and thank you all for being here this morning with us. As Carmen said, I'm Joan, and I'm co-founder of Tend Health, and this morning we're talking about advanced trauma-informed skills, really for yourself, and also as we take care of ourselves, we are also applying these trauma-informed principles to our care with our patients. Let's see if I can get these to move along. So this is the series. We were running a two-part series, so 3 sessions and 3 practice sessions in this series, and then a second series starting in April, which will be 3 sessions and then 3 practice labs as well. We will, I think the bread and butter of this topic is really in the practice lab, so I hope you come and join us for that. I'm really talking through how do you apply these skills. We do provide mental health and well-being services to individuals and organizations. Certainly we're not selling anything, but we do need to tell you that we are, that's part of our business. So here are the learning objectives for today. Really we're focusing mainly on, I just had, all my screens go away, okay. We will be focusing mainly on kind of, we're going to do real brief review of trauma-informed care, but then kind of get into the nuts and bolts of trauma-informed care. So before we can talk about trauma-informed care, I want to bring us back to what Tina shared with us last time about the stress response and trauma. And I want to say, before we even go into this, that when we talk about trauma-informed care, we inherently are talking about trauma. And that can be triggering for us as you as an attendee, or even us as presenters. And so I want you to really pay attention to yourself, your body, your emotions, and anything that you might notice that's turning you, that you might be getting activated. And really being compassionate with yourself this morning, and realizing that if there is something that gets activated for you, that take care of yourself, to either step away, to shake it off, or change body position, to get a drink of water, or to do whatever you need to do in that moment to help yourself regulate. So we'll talk a little bit more about that too in these next couple sessions as well. So I put the slide up here. The traumatic experiences are really, can be events that happen to someone or can be witnessed. And there's certainly acute traumas like witnessing a death, being in a car accident, even something little like having a young child that's in your care touch a hot stove, something like that. And also kind of chronic traumatic situations, which really are around safety. So being in a dysfunctional family where there is abuse or neglect, living in a neighborhood that's unsafe, living in a time in a war-torn country, or even in a country like ours at times that's very divided, and worrying about your own safety or ability to be safe in your neighborhood or city. And then the idea of complex trauma, which is multiple traumatic experiences, and complex trauma is also the combination of a traumatic brain injury and like a PTSD picture as well. We use that language for that. So just a reminder again that well, I just want to say, just because you've experienced or witnessed a traumatic event doesn't mean that you develop PTSD or really have any everlasting or lasting effects, but you can. And that most likely, if you've experienced trauma, you have experienced the stress response in your body. And I think that it's really important to just go back to how pervasive the stress response is on our nervous system and all of the organ systems in our body, and to remember that it affects not only our kind of brain and central nervous system, peripheral nervous system, but it's affecting our digestion, our reproductive system, our vascular system, our cardiac system. So it's really, it's a very pervasive physiological response. So trauma-informed care, you probably have all heard of trauma-informed care and may even be experts yourself in trauma-informed care. But trauma-informed care is really a lens for looking at how we practice and how we are with people and our built environments. So really the tenets of trauma-informed care, and this comes from the definition from SAMHSA, is really realizing the impact of trauma and understanding potential paths for recovery, recognizing the signs and symptoms of trauma, and responding by seeking to not re-traumatize or really, if activation is going to happen, for example, we might know that getting a vaccine or, kind of, I'm thinking about all the vaccines kids get, can feel really scary. So their stress response may be activated, but there are things we can do to help an individual through that experience and to help them regulate both before and after. So really, if there is going to be some unavoidable stressor, that we are also attending to acknowledging that it's a stressor. So these are the tenets and really the principles that inform our, how we think about our behavior, our environment, our policies, our procedures, And I think trauma-informed care has really gotten a misnomer at times, because it's really about trauma-informed practice. It's not all about the care, but you're actually practicing the skills. It's a way of seeing kind of seeing your own behavior and how we interact with our patients, our colleagues, and really even ourselves. So these are kind of what we'll be continuing to go back to throughout today and the praxis lab. So I think it's just important to point out trauma-informed does not mean trauma-specific. Trauma-specific is really a, and I can't see the chat, so if there's anything going on in the chat, feel free to put comments or questions in the chat, and maybe Carmen can read those to us. So I just want to say that trauma-specific is really a service that treats trauma, like EMDR or CPT. It's a very a specific intervention to treat trauma and promote healing. And trauma-sensitive is really around being aware of trauma, but not necessarily that last part around actually taking steps to reduce the reactivation or activation, re-traumatization. So I want to point out, so there was a study done looking at could we predict kind of a commitment to trauma-informed behaviors, and what they found was that trauma, and actually it was a colleague of mine's dissertation, and what they found was trauma is prevalent, that these three beliefs can actually predict the commitment, someone's commitment to trauma-informed behavior. That we believe that trauma is a prevalent experience, that trauma can influence behavior in adulthood, so childhood trauma, and that interpersonal behavior as well as coping behaviors, that it can influence both of those. And then that service settings can be re-traumatizing. So I think what's interesting here is these are the three things that they found, that if people were high on these beliefs, then this predicted more trauma-informed behavior. I think I just wanted to kind of think about like the trauma-informed health professional. So what is that? What does that mean for us? And really that means that we're aware, we're sensitive and responsive to trauma, and that we're kind of looking through a lens and practicing universal precautions, which I'll talk about in a little bit. But thinking about just some real quick actionable tips here for what you can ask yourself in any given moment around, am I being trauma informed? Is this trauma informed? Which can be like a big can of worms, because there's so many ways that we can make something trauma informed. But it really goes back to, is this creating a sense of safety? Is this sense safe for me? Is this safe for my patient? And is this safe for my colleagues? And am I and others showing respect? So just going back to dignity and respect and thinking about, in this situation, are we showing respect? And does this build trust? Are my actions or what's going on building trust, or is this an interaction that is unpredictable and maybe not building trust? So these are the kinds of questions that you can ask yourself. They're real simple, they're real short. Safety, respect, and trust to think about as you go through your day. So I think it's important as we talk about kind of advanced trauma-informed skills that we can use with patients, is really to talk about interpersonal neurobiology. So IPNB is really a theory that integrates so many different sciences, but really the way I look at IPNB is that this is looking at the neurobiology of our interactions and us as social beings. Really, our brain is a social organ. it really, it is constantly perceiving threats from a more of a social interpersonal lens. So if you think about it, when we still are very interdependent, but if you think about it, way back when we were kind of cavemen, that we were very much a tribal species. We're very much a tribal animal, and that we are constantly wanting to be and needing to be part of our group, part of our family, or part of our tribe, because that actually would dictate our survival. If we were not part of the tribe, if we were rejected from our group, then we would most likely die. And so we still have that instinct in our body and in our minds. And so we are constantly, and this is a lot of where implicit bias comes in, where we're constantly scanning the people in our environments. Are they friend or are they foe? And and we're constantly evaluating our interpersonal interactions for rejection or threat of being kicked out of the group or kicked out of the tribe or rejected. And so much of our behavior is about being accepted and being included in the group or in the tribe. So I bring this up because I think it's important when we're thinking about people who have had experienced relational trauma. Many of us, many of our patients, this is very common, and how this affects how we interact with people and how we experience rejection and how scary that is and how threatening that is. And I also think it's important to think about so much of our behavior is driven by the need for acceptance into a group. And you can see, and so I also want to say that interpersonal neurobiology is also just functioning in a one-on-one interaction. We have these amazing neurons called mirror neurons, and they really pick up what is happening emotionally for the other person through their affect. And so when you see a picture of someone smiling, you are actually, your mirror neurons are firing and saying, oh, that person's happy, that person's safe. I can feel happy, I can feel safe. And so actually when we see all these different pictures I put up here really show different emotions. A lot of them are smiling. I think the guy who's with the stethoscope might be a little worried. I think the girl with the mask might be, I don't know, worried, mad, not sure. And then the three people in scrubs on the stairs, they look sad. And actually each one of these will elicit a different emotion for you as well. And so I think that's a really, really important point here. When you're thinking about trauma-informed care, also understanding that you are picking up on other people's emotions through your mirror neurons, through our interpersonal neurobiology, kind of neurocircuitry, and you're also they're perceiving yours. So when you walk into a room and you're anxious, whether they're conscious of it or not, they're picking up on that on a neurobiological level. So I wanted to just think, so these are a bunch of teenagers, and I think that this need to be included in the in-group and everything, so much of that comes out and is highlighted in our teenagehood. Really middle school and high school, the whole process of how am I accepted? I think there's a lot of wanting to look a certain way or be into certain things, and there's so much around social in-groups. And so that we see that and behavior that drives us towards that with teenagers. We see that in military units as well. It's a lot about functioning as a team. It's a lot about having each other's back. And we see that as well. Here, these are all people who are being trained as lifeguards. And again, it's just there's this drive to be part of this in-group, and particularly in the military and in a situation like this, where you really need your teammates to possibly save your life. And so I think that this really highlights kind of an extreme of why for many of us, being liked is very important. And when we're not liked, or when someone's angry at us, or when we can't, sometimes setting boundaries even with a patient or colleague can be so uncomfortable and cause us so much distress, because it's really scary to think about someone not necessarily, and again, this is like, broad brushstrokes here, but not necessarily want to include you in the group, or what that would mean for you to be rejected. And I think I included this picture. This is a picture Tina had found and included in last 2 weeks ago's session. But I guess I wanted to just highlight that we also are, we absolutely are striving for or looking for acceptance and love. And we all are, I think that is another piece that I think ties into trauma-informed care, is that what you have to ask yourself, what is your, let's say it's a patient or someone who you're working with who's upset or having some disruptive behavior that may be tied to their history of trauma, is what are they ultimately looking for or needing? And much of it is acceptance and love. But they also they're trying to protect themselves from being hurt again. And so there's this conflict, this internal conflict. And you may have experienced this with your patients, who can be really challenging in the office, or really challenging with help seeking, help rejecting. But I think there's this internal conflict of, I've been hurt by the people who've taken care of me, but I desperately want to be taken care of and loved. So kind of switching gears a little bit, I bring back this Naomi Rachel Remen quote, that the expectation that we can be immersed in suffering and loss daily and not be touched by it is unrealistic as expecting to be able to walk through water without getting wet. This is how I feel about work, medicine, and healthcare in general, that we are constantly around people who are in pain, who are suffering, who are going through scary experiences, they're anxious, and they come to us for help. And how can this not, from an interpersonal neurobiological perspective, how can this not shape us? How can this not affect us? We are social beings. Our brain is constantly picking up on other people's affect. And to think that doing this work and not being affected by it, that seems totally unrealistic to think that would happen. So I want to turn towards, and I'm just doing a quick time check. I want to ask you, when you think about your day-to-day practice, whether you're an inpatient or outpatient setting, whether you're a student or a 20, 25-year veteran of practicing medicine, what are potentials for activation for you, or what have you noticed? Where do you notice getting activated for you in your practice? And I was hoping you could just chat in, and if I think you have the ability to do that, chat in just a few places that you find you get activated, and it could happen even before you get to work. I have a very good friend who says, I'm most anxious like the hour before I arrive at work, because I'm just thinking about what's, once I get there, I'm fine. But I kind of make up worst case scenario. So I don't know, Carmen, if there's any chats coming in, or anybody has a thought about times or moments or interactions or things that activate them, or are potentials for activation.
We have Christy sharing with us that fragrances are disturbing for some patients.
Can you say that again?
Fragrances are disturbing.
Fragrances.
Yeah, are disturbing
Yes.
for some patients.
Mm-hmm. Yes. Well, so our senses, and our sense, the sense of smell goes directly to the limbic system. And so it is a very fast track to, is this safe or is this not safe? And yes, we actually have very strong memories of smells. It's a very, very strong imprint. And so fragrances and smells can certainly be activating.
We have another participant, Carrie, checking email, getting overwhelmed and discouraged.
Yeah. So anybody have ideas around why checking email can feel so anxiety provoking? Well, I guess I think about sometimes things get communicated in email that are really probably not appropriate for email communication, but it's the most efficient way to share information. And so we communicate things that can be quite, that can really evoke emotion. I also see that with kind of not my chart, in-basket messages with Epic. So we often have to share pretty significant information through an in-basket message. And also the volume of email, and also the fact that we might be being asked to do a million things that might feel overwhelming, or that we might not know if we have the abilities, skills, or knowledge to complete. Anything else?
Sorry, we have another comment. Christy is mentioning that media plays a huge part in potential activations too.
Yeah. So both social media and radio and television, there is a lot of, I think sometimes people can get misinformation through those methods. Their fear can be triggered, and so they already come into our interactions activated with a lot of fear around many things. So thanks for bringing that up. So thoughts on reducing potential for activation. Are there strategies or behaviors or actions or communication that can reduce the chance of activation or retraumatization? Anything that you guys are using? Anything that you found just kind of your go-to? So we're going to talk I'm going to give you kind of some oh, go ahead.
I can't chat in. So hi, everybody. It's Tina Runyan, Joan's colleague in this. And so I can't chat into everybody. So I wanted to, I mean, this may be a little premature, but I wanted to ask about a strategy that I sometimes use, and I don't know if it reduces activation. I'd be curious to hear your comments on this. Certainly that wanting to be seen, wanting that connection, wanting to be sort of part of a group leads me to share stories, sometimes bordering on complaining. The things that are very activating for me is if a patient is mad at me. I can handle if a patient is mad. I really liked that share around fragrances. And how activated other people can get when they smell something unpleasant or a fragrance on someone else. So I can handle that kind of mad, but when somebody really directs that at me, that's very activating for me. And my way of trying to handle that sometimes is to go to my social supports and to complain and to maybe even say some things that aren't so flattering about that person that is mad at me. And in the moment, it does feel like it validates whatever I'm experiencing. But I'm wondering if you can comment on that, because I'm not sure, listening to you, that it's that it is trauma informed.
Well, I not that I want to make this a therapy session, but I think this will be really helpful for for everyone listening, which is to kind of go back to why it's so activating when someone is, and particularly a patient who you're caring for, is mad at you. And I think about when you were a little girl, or when any of us were little, that if our caretakers were mad at us, we may have not gotten our basic needs met. And so we do everything in our power, for the most part, except when we're toddlers and teenagers, and maybe in between, but for the most part, to please our caregivers, to make sure that our basic needs are met. And this is not conscious. We're not a 5-year-old being like, oh, I'm going to give mommy a kiss right now, or I'm going to bring mommy this picture because she's going to feed me and clothe me and hug me and love me. It's just part of our nature. And so thinking about why it's so activating when someone is mad at us is that it taps into those really, really primal fears of not getting our basic needs met. And what that could mean in a work setting, it could be, oh my gosh, my patient's going to complain and put in a complaint, and then I could lose what if I lost my job, and then I might not be able to put food on the table. Like, our brains go to that place. So I wanted to just say that because I think that's a pretty universal experience for a lot of people. And it helps you maybe understand why it hits so deeply. The second part about complaining to your colleague or venting is that I don't know if it's not trauma informed. I think that what you're tapping into is kind of the empathy piece of you're looking for, maybe you're looking for validation, and that you're part of what I think we look for when we talk to our colleagues about stressful experiences is that you're okay. Mm-hmm. And to validate that was a stressful experience. And I think for many people, we can hold that for others. And for some, and in sometimes when you share something, maybe your patient told you something really, really tragic and traumatic, and now you're telling me that as your colleague, and that might be activating for me. So even checking in when you're talking to a friend or a colleague of like, I had my patient told me this crazy thing. It's kind of big. It's kind of like, maybe it's about something like sexual abuse. Maybe checking in with your friend or a colleague and saying like, it's about sexual abuse. I just want to check in with you before I share that, share the details, because I found it really triggering, and I wanted to check in with you about being able to share those things. I don't know, does that?
Yeah, really helpful. And I appreciate you kind of recognizing that behind that activation when somebody's mad at me, that as I've gotten working on a lot of sort of self-regulation and grounding and mindfulness practices, I actually can very clearly tap into that fear that you're describing. And then I can work much more directly with that fear myself to dysregulate. And interestingly, as I'm listening to you, it also has meant doing less of the going to other people and maybe sort of sharing that, passing along that activation. So thank you. Yeah.
And I think sometimes we hear so much. We know, I mean, if you work in a specialty where you're doing a lot of cancer, diagnosing of cancer, or giving prognoses that aren't great, or doing a kind of giving bad news a lot. I think we get used to that, but you have a lot of, you will have cases that are really hard for you and really tap into something and are very activating. And we often will just go to our colleague, and I'm guilty of this with my colleagues, and probably you too. It's like, you're just like, oh my God, this thing happened and blah, 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 right? And then you're like, wow, that was pretty, like, could be triggering content, pretty activating content about something, and not really thinking about, wow, I just shared with you that I just had to give a cancer diagnosis to a 22-year-old, and maybe you have someone in your family who's going through cancer treatment, or maybe yourself was diagnosed with cancer at 22 and I don't know that about you. So we're going to move on, because this dovetails right into the idea of universal precautions. And thinking about, and that's number 8 on the list, but we'll talk about it first. Thanks, Tina. Universal precautions as an approach towards everything, all of our interactions with patients, all of our interactions with colleagues, is thinking really going into an interaction assuming that people have a history of trauma, and not needing to ask questions, not needing to use screening questions, or just assuming. Trauma is so prevalent that it makes sense to assume. Just like we put on gloves when we're doing anything with body fluids, that we don't ask, do you have a bloodborne pathogen? We just put gloves on. We just do it. That's just what we do. And that, I think masking will kind of become like this in the future, right? We're not going to be like, did you have COVID, or are you COVID positive? I think we'll just probably wear masks. It will just become a universal precaution. So these are 8 behaviors that I like to teach people kind of out of the gate, for little things you can do that are super actionable but can make a big difference. They're kind of the low-hanging fruit of trauma-informed care. So always introducing yourself and your role, and in a setting where you might be popping in and out, or you might not see someone for a really long time, it never hurts to reintroduce yourself, especially if, even if it's like you have an annual visit with someone, and it's okay to say, they might just say, oh, I know who you are. But if they didn't, or maybe they didn't know how to pronounce your name, or maybe they kind of forgot exactly what your role is, that can go a long way. Then they can understand what your capacity is for helping them. And then use open and non-threatening body position. I think this is really, over 75% of our communication is nonverbal. It's our body language, it's our tone of voice, it's our cadence, and it's our nonverbal facial expressions. So really paying attention to what your body and your voice are saying, less about the words, actually. And this is like, I always use the example of, like, we talk to babies and animals like this, and we're like, oh, you're so cute. And they probably wouldn't know the difference if we said, oh, you're just such an ugly little baby, or oh, you're such an ugly little doggy, because they're listening and hearing and attending to the tone and the cadence of your voice. And maybe they understand the words, but like, even when you listen to other languages, people can say, essentially, they can often tell you what emotions being expressed, but they don't understand the actual words being used. So also providing anticipatory guidance. This is huge. Part of what builds trust is being able to predict how someone's going to act, or what something's gonna feel like, and for it to be reliable. And so when we give anticipatory guidance, even you're gonna go, like, after a procedure, maybe it's You're going to go home, you're going to feel a little uncomfortable. You know, you might feel some aches and pains in this part of your body. Here's a few things you can do. Here's a few things that if this happens, I want you to call me. And here's what you would need to do. If you've experienced these things, you go to the emergency room. These are it's kind of but also it can be just really in the moment anticipatory guidance. This goes into the ask before touching piece. We did a survey of primary care providers, and we also observed their practice, and we realized that patients actually expect to be touched in the context of a medical visit. So, and probably because of that, people don't ask if they can touch their patient. But actually, it creates quite a sense of safety and choice for the patient to actually say no, or give you some information about how they'd like to be touched or about their body. And we don't see people actually doing this, asking. Would it be okay if I listen to your heart and lungs? Just simply asking the permission. Or would it be okay if I touched your back? Or would it be, can I do a gland exam or lymph exam, where people that touch your neck? Now, if you've ever experienced strangulation or any kind of abuse around your voice or your throat, having that exam could be very triggering. And we didn't see people ask those questions. And again, it's that practicing universal precaution. So really, really, I encourage you, maybe going into your practice these next couple days or next week, to practice asking your patients before you touch them. And also letting them know what kind of touch and what it might feel like. I'm going to put some pressure here. I'm going to put my hand is going to move down your arm, kind of telling them before it's happening. One of the things we saw was that people told people what it was going to be like as it was happening. And so patients and people, they don't have time to prepare or to tell you something like, oh, that's a really sensitive area, or, that I have pain there, or actually that's a place I'm kind of numb on my body, or anything. So I could talk about this stuff all day long, so I'm going to try to move on. So also protecting patient privacy, really, really thinking about how you, when you share information about patients and how you share information about patients, and really making your best effort to only share information and as much information as needed with the people who need to know. And this comes up a lot in inpatient settings where patients are in a shared room, or where you have to round and discuss patients in a hallway. Or maybe in a primary care clinic where there's lots of people in a small space. That's probably not happening as much now, but just really, really thinking about who is around you and who could be hearing this information. And particularly in inpatient settings when you might have family or friends around, and again, we don't see as much of this right now with COVID and the restrictions of visitors, but asking the patient to actually having families step out of the room and then asking the patient, is it okay to discuss today's plan or whatever it is that you're going to discuss with them with their family or support people? And then if the patient says yes, inviting them back in. But when you ask that in front of people, then the patient truly may not feel safe saying no. I actually just want this information shared with me. So really thinking about privacy. Providing clear and consistent messaging about services and roles. I think we can do better on this than we do. I think when you meet a patient in your role, be very clear about what you do and what you can provide from the outset. from the outset, I think that there are lots of expectations people have of us because we haven't been clear about what we can and cannot do for them at the outset. I think that oftentimes people expect more than what we can do, but that may not be their fault for expecting those things because we haven't been very clear with them about what we can do. And sometimes that need comes up in the moment when there's an ask that you haven't necessarily anticipated, and you have to set a boundary in the moment, but being very clear about that from the beginning. Using plain language and teach back, we also didn't see a lot of teach back in our observations. And I think maybe people, it takes time to be like, okay, so we talked about a lot today. Tell me what the plan is going to be, and really get that they understand what's going on. And then we talked about practice universal precautions. So I'm hoping those kind of are some actionable tips that you can take away that can be really the kind of big bang for your buck there. So I just wanted to quickly introduce the idea of trauma-informed communication. It's and highlighting these words that I put in bold: honesty, clarity, respect, empathy. I think what's really important is that we're less likely to trigger patients or to be triggered ourselves when we are guided by these principles. That if we can have compassionate boundaries. So I think that we because of the interpersonal neurobiology underpinnings that we talked about today, setting boundaries can feel really hard. And but if we can communicate compassion and respect and set boundaries, which I'm not saying this is easy, not saying it's easy, but that is what our goal, that's our intention here. Just some tips here and kind of some ideas of, as soon as you get defensive, as soon as we get defensive and our hackles kind of go up, we are no longer in that place of compassion. When you start to feel like you need to protect yourself, you've gone into kind of fight, flight, safety mode. So if you notice yourself becoming defensive, I would suggest grounding yourself, putting your feet on the floor, taking a breath, and even saying that, you know, I need a moment. I'm going to take a breath. Give me a second. And so I think what I want you to take away from this is that the number one thing that we all want is to be heard and seen and validated. And if you can validate someone's experience without agreeing with it, you can say, you're really mad. This is really frustrating. You don't feel like you're being taken care of the way you want to. You're not saying you aren't being taken care of the way you want to. You're saying you feel this way. That can go a long way. And here I just give an example of setting a boundary, but giving a choice. Okay, giving choices can be so powerful. So someone, let's say something's kind of getting complicated and there's some conflict, maybe you're on the phone and you say, would you like to, maybe someone's getting loud on the phone. You could say, would you like to continue working together to figure this out, or would you like to stop now and continue at a different time? So it's like you're setting a boundary, but you're giving them a choice. So just some takeaways. Trauma-informed communication, and just kind of going to the trauma-informed organizational approach is really, really much different than kind of the behaviors we've been talking about. But to create systems for addressing trauma exposure, I think is the piece that I want you to think about most, and kind of acknowledging the trauma exposure in the workplace, and then actually doing something about that. I think that we can all say that a lot of our jobs, we have a fair amount of exposure to traumatic events and to other people, to patients' stories, kind of a secondary trauma, and that what are our organizations, what are our workplaces doing to support us in that experience? How do they support us taking care of ourselves, or how do they help us to how do they take care of ourselves or take care of us? Not saying that this is kind of new. I would say that we work in lots of systems that don't do this, and I'm not saying that if your system doesn't really have anything that supports you in this, that this is a very new thing. And to really look at policies and procedures that may be potential for re-traumatization as well. Yeah, so I'm going to invite Tina to come back and kind of share with us a little bit of kind of the last couple slides about just what happens for us with so much exposure to secondary trauma, and then how we can take care of ourselves.
Thanks, Joan. I'm just noting the time too. So everybody has these slides. They're pretty detailed. So want to just also allow Carmen to nudge us if there's a question. But I guess one of the things I want to say about what you're seeing on the screen now is that, again, back to that Rachel Naomi Remen quote, is if you are experiencing any of these things based on the work that you're doing, this is not a personal failure. This is not because there is something that you're not sort of strong enough or good enough or anything enough. That we are all vulnerable to feeling any number of these things at different times. Sometimes people experiencing it straight, really soon out of training. Other people, I've been doing this for 10 years, I've been fine, why now? Lots of reasons why now. But this is not about a personal failure. And to Joan's point, that organizations are now just beginning to understand how, when a clinician may be struggling with some of this, the right answer is not, well, maybe this isn't the right job for you. The right answer is really to validate and to appreciate that this is inherent in the work, that we are walking through water, we will get wet, and how do we care for ourselves in that time? I'm guessing there's a question, Carmen, because I see your lovely face here.
Yes, there is a question, and I just want to go over the final details really quick. So let me take the screen really quick. And yeah, just remind everybody that I'll send you the instructions for getting your certificates today via email. Just wait 1 hour or two after we finished. When you please claim your certificate, because when you claim your certificate, you will be asked some questions, and we need you please to fill out the program evaluation, and we will really appreciate it. Remember, the activity code expires in 1 week, and the webinar is being recorded, and we're gonna be posting it on our YouTube channel, and I'll share the link with you as well on that email. And any questions, any issues, please send me an email. Everything is through email now. This is the code that you need to remember. We have, they're just asking about the activity code. So perfect, it's gonna be there on the screen. And now let's go with the first question. What is the best way to set boundaries, especially if you have a very needy person who maybe pushes limits in terms of reaching out to you as a care provider?
My short answer is come to the practice lab.
Yeah, come to the practice lab. And we have like negative minutes. So, but I honestly think the best formula for setting the boundary is acknowledging the person's experience and setting the boundary and giving them a little bit of the why, and not giving them just enough of the why that, you don't have to say, well, if I responded to your 20 MyChart messages and everyone else's 20 MyChart messages, I would never sleep. You don't have to say that. You just say that, I would have to think about exactly what I would say, but something to the point of that MyChart is to be used only is just for quick communication, and anything that's more than a couple sentences probably requires a phone call or a visit, and like redirecting, but first acknowledging their experience, whatever that is, and then setting the boundary and giving them a little bit of the why and giving them a choice for, you can do this or you can do this.
I love that. Oftentimes the boundary comes in the form of stop doing this, but we don't give the alternative of do this. And so I love that description of boundaries. It may include a little bit of like not doing this. Here are your other options, do this. So it gives people something to turn towards.
And I know, Carmen, we have to stop, but just one thing. It's really hard to set compassionate boundaries when you're activated yourself. If you are interacting with a person, you are activated, it is really hard to stay in your integrity and set a calm, clear, compassionate boundary. And it's really hard to acknowledge someone else's experience when you're already in fight or flight. So the first part of that is the self-awareness of, where am I at right now? And how can I get regulated, or how can I bring myself back to being grounded and regulated to be able to have that boundary setting conversation.
And if you have more questions, you'll have time to ask them. We're gonna have the lab practice about this topic on February 25th, same time, same day of the week. So we hope to see you in 2 weeks to continue with this topic and answer your questions and do more. Right.
And write your questions down from today and bring them on the 25th.
Yeah,
and we can start there.
That's a great idea. Or email them to me and I'll have them ready for that day. And I'll share them with Tina and Joan, and they'll have them beforehand. Okay. I'm getting comments about thank you for the presentation. Kudos as always, and any question, just email me. I'm gonna send you an email with all the instructions, all those little bits that you don't have time to remember because you're focused on the presentation. No worries, I'll email you in a couple of hours. And thank you so much for joining us today. Thank you for being up so early. Thank you to our wonderful speakers for sharing your knowledge. And thank you everybody for participating today. Now you have completed today's session and you may disconnect. Have a wonderful day.